Hello, my name is Chris Nielsen, and I am a Master's in Public Health candidate at Boston University, serving as a consultant for Treatment for All, or TFA, a Guinean non-governmental organization, or NGO. I am making this video with the intention of improving the quality of care at one of TFA's clinics. Allow me to first provide some background info about TFA, and then I will analyze and address the scope of work, describe the deliverables that I would produce, and identify key challenges anticipated. Treatment for All has the main mission of building public and private sector capacity for the clinical care and treatment of individuals living with HIV/AIDS and its associated diseases. Through a variety of programs and partnerships with governments and NGOs, TFA supports over 170 sites and funds the clinical care or treatment of over 125,000 HIV-positive individuals. HIV counseling and testing is also provided by TFA to 230,000 individuals annually. The Total Life Clinic, TLC, is the TFA flagship ART clinic in Conakry, Guinea, and is funded chiefly by grants from the United States government and through the President's Emergency Plan for AIDS Relief, PEPFAR. It is situated in a large public hospital and currently provides care to approximately 18,000 patients on ART. This translates to 3,738 monthly medical visits. Aside from medical visits, patients also visit the clinic to collect ARV medicines and for laboratory tests. There is rising concern that this large and growing number of patient visits is overburdening the clinic staff and 8 physicians. A recent study followed patients around the clinic and found that patients are waiting a long time to see a physician. Oftentimes, when physicians and staff are overworked, errors occur and their quality of care is therefore compromised. Consequently, patients may become dissatisfied with the care they receive. The deliverables that I will suggest in a moment will focus on these areas of inefficiency and offer suggestions on how to reduce the burden on staff and physicians. A typical day at the clinic begins at 7:30 a.m. Clinic staff and doctors begin seeing patients at 8 a.m. 86% of patients arrive before 9:30 a.m. This situation is much like a rush hour traffic jam that could be alleviated if appointments were scheduled ahead of time and patients showed up at their scheduled appointment times. I suggest that TLC hire a secretary who can make and manage patient appointments at regular intervals during the clinic's operating hours. After reviewing the patient flow map, a few key points and areas of inefficiency stood out. First off, regardless of whether a patient is visiting the clinic for a pharmacy or medical visit, the patient waits over half an hour to give their handwritten patient information to the registrar. These handwritten blue cards are then used to locate patient files, which takes nearly an hour. There's a number of intermediate, but not particularly time-consuming steps that culminate in a patient waiting to receive their medication or see a physician. The 3 most time-consuming steps of this process include the initial patient entry and file registration, and then the wait to see the physician, which is approximately an hour and 21 minutes, or to receive a prescription, which takes about an hour and 4 minutes. These should be the areas of focus. I will now describe some of my suggested deliverables. Staff focus groups meetings could be designed to discuss concerns or difficulties encountered delivering patient care. For example, one group meeting could discuss why patients who have scheduled appointments don't have their files retrieved ahead of time. This could eliminate the 58-minute delay while the patient files are retrieved. Patient surveys could be used to assess patient satisfaction and the success of the quality improvement project overall. Surveys may ask about the efficiency and satisfaction the patient experienced during their visit, in addition to any concerns that they might have. TLC could also collaborate with stakeholders interested in creating an assessment tool for patient flow, in addition to creating physician and staff efficiency monitoring and evaluation teams. This monitoring system could use smart objectives and indicators to assess physician and staff workflow and help identify whether or not the staff are using their time efficiently. If it is found that the patient wait times are not improving and the workforce at TLC is simply inadequate, then I would recommend collaboration with different organizations who might offer additional staff in the form of nurses or community health workers. This collaboration is in alignment with TFA's approach of forming partnerships with the private sector and other NGOs. For example, CHWs could be in charge of locating patient files and attending patients in the waiting area, while nurses primarily take the vitals and triage patients. To address the long wait at the pharmacy, standardized prescriptions should be prepared before the patient arrives. Since this is an HIV/AIDS clinic, most patients are probably visiting the pharmacy for similar prescriptions. If these deliverables are followed, I am confident that the efficiency of TLC will improve. However, funding challenges and challenges with physician and staff buy-in may occur. Physicians and staff may not be receptive to suggestions and tools from an outside consultant's quality improvement team. To address this, my quality improvement team would emphasize the holistic inclusion of current staff and physicians in the quality improvement efforts. To address the funding constraints, efforts must be taken to find resources and grants from foundations such as PEPFAR. I hope my analysis of the scope of work and the deliverables I have suggested will help alleviate the physician burden and reduce patient waiting times, thereby facilitating access to HIV/AIDS clinic services. Thank you for listening to my presentation, and enjoy the rest of your day.